Hi, everyone. We're going to get started now. Thank you for joining our CareOptimize COVID-19 Insights meeting today. The first thing that we're going to cover on today's meeting is the CMS updates. So a lot of things came out this past week. The first thing that we're going to talk about today is MIPS Updates. So you may have heard that the deadline for your MIPS attestation has been extended. It was previously March 31st of this month. It has been pushed to April 30th of next month, 2020. MIPS eligible clinicians who have not submitted any MIPS data by April 30th will automatically qualify to receive neutral payment adjustments for the 2021 payment year. So if you have done your MIPS, we still recommend attesting. However, if you do not submit, you will automatically get a neutral payment adjustment for the 2021 payment year. As far as the 2020 data submissions go, they are still evaluating options, providing relief around participation. So we currently don't have any details on that, but as we get those details, we will let you know the latest information. Some updates that we have gotten, though, on 2020 data submission for hospital programs is that CMS will not count data from January 1st, 2020 through June 30th, 2020. And some examples of those hospital programs that are involved are ambulatory surgical center quality reporting programs, hospital-acquired condition reduction programs, hospital inpatient quality reporting programs, and there are many others, but those are just a few examples of some hospital programs whose data will not count from January 1st through June 30th of this year. Okay, another update that we received from CMS is regarding the waivers. So on Monday, March 23rd, the President had a conference call with the governors. During that call, they discussed that CMS approved a waiver request under Section 1135 under the Social Security Act that states the following that you will see on the screen. We are temporarily suspending prior authorization requirements. They are extending existing authorizations for services through the end of the public health emergency. They are modifying certain timeline requirements for state fair hearings and appeals. The states that are included with these waivers currently are, the first two were on March 2nd, were Florida and Washington State, but currently the additional states that were added are Alabama, Arizona, California, Illinois, Louisiana, Mississippi, New Hampshire, New Jersey, New Mexico, North Carolina, and Virginia. So if your practice is located in one of those states, then these waivers apply to you. That's not to say I'm sure other states will be joining, but currently those are the only ones that are affected by the COVID-19 waivers. Okay, so during this time, I'm sure it's a very stressful and busy time at your practice. There are ways, however, to have additional revenue resources come in. So we're going to go over a few of those next. So one primary source of revenue that you can still have during this time is with telehealth and telemedicine. So you may hear these terms interchangeably, but there are some major differences between them. Telehealth is different from telemedicine in that it refers to a broader scope of remote healthcare services than telemedicine. Telemedicine refers specifically to remote clinical services, and telehealth can refer to remote non-clinical services. So some key points that I want to point out with telehealth and telemedicine is that CMS waived the qualifying rural area facility requirements during this current public health crisis. The Health and Human Services and OIG gave providers flexibility in either reducing or waiving patient cost-sharing portions, and, for example, copays. HHS will not conduct audits to ensure prior relationships existed during this public health emergency. These telehealth and telemedicine visits are not just restricted to the COVID-19 visits. So if your patients have rashes, if they have cold symptoms, if they're having other symptoms not related to COVID-19, you should still try to see your patients through a telemedicine visit. Additionally, state Medicaid and commercial payers have also announced that they will have flexibility around telehealth and telemedicine, but those details are currently not available, so please contact your local payers for their specific requirements. Okay, another way that your practice can continue to bring in income during this time is to have them enroll in the chronic care management or the principal care management programs. So patients can be enrolled in both of these programs at different practices. So for example, if you are an internal medicine practice, family practice, then you would likely be a chronic care participating in chronic care management. The principal care management is primarily for specialties. So I'll get into that a little bit more. For chronic care management, the patient must have at least 2 medical conditions that are expecting to last at least 12 months. So that's why these are more for your family practice and internal medicine doctors. Some care requirements that are a little bit different from the principal care management is these non-face visits need to be at least 20 minutes. The principal care management, the patient only needs to have one major chronic problem lasting 3 or more months. So that's why these are primarily for specialists. So, for example, if the patient has arrhythmia and you're a cardiologist, you could participate in the principal care management. Or if you're an endocrinologist and your patients have diabetes, that would be good for you to participate in principal care management. So in regards to identifying the patients at most risk for COVID-19, the CDC recommends the following diagnosis as an increased risk. So if they have lung disease, moderate to severe asthma, serious heart conditions, cancer patients, severe obesity with a BMI greater than 40, immunocompromised or immunodeficiencies, including smokers. Okay, so you may be thinking, how much revenue could these programs potentially bring in? These could potentially bring in about $43 per patient a month or $40 per patient per month. Somewhere around there. It does vary depending on your location. We would recommend running a report to identify these patients, and the programs, could lead to additional revenue for your practices. These programs also can still continue after the public health crisis is over, so these don't need to stop. You can keep following up with your patients and continue the chronic care management and the principal care management programs, whatever one works better for your practice. We are currently offering complimentary Nextgen COVID-19 tools. So if you are on Nextgen EHR, this applies to you. We have, I have some screenshots displaying our coronavirus COVID-19 template and the documents. So this template and corresponding document will walk your providers through the process of handling a potential coronavirus case. It screens for other potential case causes of the patient's symptoms. For example, if they have been tested for influenza or if they've been tested for pneumonia. And it also has the ability to document specific actions and details concerning the case. Also, for example, if the patient was wearing a mask, was the staff wearing personal protective equipment? Was the room sanitized after the patient left? How long were you in contact with the patient? And additional other things that would go into the incident report. We also have a coronavirus CRISTR report. So the CRISTR report generates a list of your most at-risk patients for the coronavirus based off the patient's chronic conditions. It can be used for patient outreach to ensure that your most at-risk patients are receiving appropriate care. And just as additional, the templates are complimentary, so at the end of this presentation, I will have my email address, so if you are interested in these, please let me know. So next week's webinar, we will be discussing 3 different groups that we're currently working with in the South region in Florida and Georgia that we have implemented services for COVID-19 and additional services that can be used to produce the additional revenue streams during this crisis. The practices are very different. We have capitation versus fee-for-service payment models. We also have a cardiology practice versus multi-specialty versus internal medicine. So if this is something that you would find interesting, please sign up for next week's webinar when we send out those invitations. And that is all I have for today. So currently all are muted, but I am going to stop sharing my screen and unmute everyone and open it up for questions. Okay, I believe you all have been unmuted. So does anyone have any questions? And I'm going to bring up my screen again just so that you can see the my email address in case you didn't get a chance to write it down. Okay, everyone. Well, that's it for today. Please let me know if you have any questions with our chronic care management, telemedicine. If you would like the complimentary COVID-19 tools for Nextgen, I would be happy to send you more information on those. And please stay tuned. Next week we'll have a very informative webinar on our case studies with the practices that have implemented our tools.